Thanks, Jorge. Thank you so much. And thanks, Nuria and Starts, for the invitation to be here today. I'm always very excited to be able to share this work and hopefully spark some discussions in the panel later on. Just following on, my background's a little bit unusual to be doing the work that I'm doing, but my work is around physical activity and the link with mental health. And I've spent probably the past 10 years looking at how we can integrate physical activity and exercise as part of routine treatment for mental illness here in Australia and in high resource settings. And did my PhD with inpatients with post-traumatic stress disorder, and then gradually have moved towards working in low resource environments and with refugee populations as well. I think what's really interesting is some of the steps that we've taken to help progress this work and the implementation of exercise and physical health within mental health treatment here in Australia. We're using the same lessons and building on that in Bangladesh and in other contexts as well. So the first thing I just want to touch on here is this idea about what is mental health care. And I think this image for me sums it up really nicely, and it sums up the disconnect between the physical health and the mental health of people living with mental illness. Now, we know that just for having any diagnosis of a mental illness, whether it's depression, whether it's PTSD, whether it's schizophrenia, people are at significantly higher risk of experiencing poor physical health. So that's an increased risk of diabetes, high cholesterol, blood pressure issues, so those cluster of risk factors known as metabolic syndrome. And I think when we talk about the structure of the healthcare system, we have these silos of physical health and mental health. And this picture sums it up with the GP there saying, okay, who am I treating first? Is it the body or is it the mind? And of course, what we know, and I'll present the evidence today, is that they're entirely interrelated. And if we're treating the mind or the mental health, we have to be thinking about the body. If we're treating the body, we have to be thinking about the mind as well. So we wrote this editorial in the British Journal of Sports Medicine earlier this year that was based on a Lancet commission that we published last year called Protecting the Physical Health of People with Mental Illness. And it was a blueprint for doing that. And one of the key recommendations was around integrating multidisciplinary care for people experiencing poor mental health. And that multidisciplinary care includes evidence-based lifestyle interventions. And I'll talk about that, but we're talking exercise, diet, smoking, and sleep. So the argument that I would make is that this can be considered mental health care as well. And it's a picture shared by colleagues who do a lot of work in Uganda, David Van Camford and Justin Richards. More closely here at home in Australia, I would say this is actually what mental health care can look like. And I've got to stress here that we're not saying that exercise replaces existing treatments. That's absolutely not the case, and I can't stress that enough. What the evidence tells us is that exercise should be offered alongside routine clinical care as an adjunct, and for two reasons. One, for mental health outcomes, but two, for physical health and to protect the physical health and to try and reduce that gap in life expectancy that we know. Just by having a diagnosis of a mental illness, people have a reduced life expectancy of up to 15 years, and that is preventable due to the premature cardiovascular disease. So these are some examples of some great programs happening all around Australia, targeting different populations, but really looking at integrating exercise as part of routine treatment. Now, this concept of what's being now recognized as lifestyle psychiatry, the evidence base is really, really strong. This was a review we published earlier this year in World Psychiatry, and this was a meta review looking at the bidirectional relationship between these four risk factors. So exercise in the top left, smoking. We know that about a third of all cigarettes smoked globally are smoked by people living with a mental illness. That's a huge driver for the inequality, particularly the physical health inequality. Sleep, we know that's vitally important, not only for mental health outcomes, but also for physical health outcomes. And this box up here on the top right is diet. And there's a really increasing body of evidence around the impact between diet and also gut microbiota and the impact on mental health outcomes. Now, I think what's been really interesting with COVID is that the WHO, and for a long time, the public health messaging around lifestyle has been really positive in terms of the link with cardiovascular disease. And people are very clear and very aware that what we eat, what we do, our sleep is related to our risk of cardiovascular disease. And in fact, when we talk about physical activity, one of the problems has been that the messaging is all around avoiding a negative. It's telling people you need to exercise so you avoid diabetes, so you avoid cardiovascular disease. instead of telling people about the positives that we can gain from participating in those activities, such as reducing symptoms, improving mood, all those sorts of things. So WHO, I think COVID has sort of it's increased the recognition of the link between physical activity and mental health, because when we weren't allowed to, suddenly everyone wanted that hour of exercise. So I just made a quick change to this picture here based on the evidence we have, just crossed out cardiovascular disease risk and added poor mental health. And the evidence is really strong, around these risk factors and the relationship with poor mental health. So we need to start conceptualizing and treating these interventions as evidence-based strategies that we don't just fund as an add-on if we have time, or if there's a bit of spare money lying around in a service, but actually the integrated component of routine care and really focusing on prevention. The key recommendation from the Lancet Commission was that this needs to be considered as part of early intervention. As soon as someone comes in contact with a mental health service, regardless of what condition it is for, we need to be thinking about physical health and trying to intervene early to protect the decline in physical health that we know is experienced. Now, when we talk about the sport or physical activity, and I'm sort of using those terms interchangeably, but essentially sport is a type of physical activity. Physical activity is any sort of bodily movement. So if I was to be standing right now, kind of waving my arms around, that's physical activity. Sport is a structured subset of physical activity that's often competitive in nature. And then exercise is another component of physical activity, which is sort of planned or premeditated. But I'm kind of using all those terms interchangeably for now. This dual continuum model here around mental health versus mental illness, I think, is really important. And I spend a lot of my time talking to the physical activity sector and that side of things. So it's a little bit different. But I think what's useful here is to think about the existing services we have, who they're actually targeting, and also thinking about what are the opportunities that we can actually increase and reach more vulnerable people through physical activity and sport interventions. So what I would probably argue is that most of the services we have, most of the sporting services, are targeting people up here in this quadrant. So no mental illness, optimal mental health, flourishing, or people that are functioning very well, and mental health is positive. And when we think about plus sport or sport plus, what we're referring to there is what is the core business of the organization or the work that we're doing. So for example, if we think about STARTS, we would say that they would be thinking about plus sport. How can STARTS add physical activity, add sport as part of their routine care? Whereas Sport Plus is thinking about who's already providing physical activity, sport-based interventions, whether it's exercise physiologists, physiotherapists, community sporting clubs. How can we enhance those with further mental health expertise? Now, one of the examples there is thinking about getting the people down in this quadrant in the bottom right, where there's not necessarily a mental illness, it's not a clinical population, but they are experiencing poor mental health. How can we ensure that existing community-based facilities have experienced things like mental health first aid training, so that the staff are prepared to engage and safely work with that population as well? We think about the other end of the spectrum. If we think about severe or serious mental illness, we need to make sure that we have the adequate support to match the needs of individuals. So for example, working with a traumatized population, we need to make sure that there's the required level of individualized support to support that person to engage in appropriate physical activity or sporting programs. So that could be right through to clinical exercise physiology based referrals, where there's a one-on-one approach that's really trying to work with the needs of that individual. Now, one of the questions I always get asked is what type of exercise is best for mental health? And the short answer is there isn't one. And this was a podcast that we recorded with a colleague, Dr. Ruth Wells, in Turkey on the Syrian border, working with an NGO over there, where we were focused on strength training. That's what those elastic bands are. So essentially it's muscle building exercises, really cheap. And the evidence is that really the type of exercise doesn't matter. So there's been, and I'll flash up a whole bunch of references here. It's just to give people so that they're there, and I'll talk a bit about them, but I won't go through it in detail. But there's been some great meta-analyses looking at the anxiolytic and antidepressive effects of resistance training. Most of the research around the mental health benefits of exercise has been done around aerobic exercise, and that's that sort of heart and lung activity, running, swimming, cycling. It's not because that activity is better, it's just because it's easier to do that research. If you think about a mental health facility, if you don't necessarily have access to specialized equipment or services, it's far easier to just tell people to go for a walk or go for a run and look at the impacts of that than it is to do a structured resistance training program. But resistance exercise can be just as effective. It's cheaper. You can do a full body workout in a couple of minutes. So there's a lot of interest around strength training. My own experience where I did my PhD at St John of God Hospital was that strength training was a really good way of engaging people early on in the program. There were less barriers compared to telling someone that's doing nothing, right, we need to get out of bed and go for a walk for half an hour. Similarly, yoga. We published a review earlier this year led by one of our PhD students, Jacinta Brinsley at UniSA, looking at the antidepressive effects of yoga for people living with any mental illness. Unsurprisingly, it was highly significant. The thing to stress here is that it was movement-based yoga. So we weren't looking at the mind-body aspects in terms of breathing or breath work or mindfulness. It was really looking at the movement-based yoga. Now, taken together, this raised some interesting ideas about, do we need specific physical activity guidelines for mental health? And the World Health Organization and Australia has their own physical activity guidelines, which essentially talk about, achieving 150 minutes of physical activity per week. Now, those guidelines are absolutely not mental health informed. They're done based on epidemiological evidence looking at essentially cardiovascular disease outcomes. If they were mental health informed, they wouldn't say we need 150 minutes. They would actually say something is better than nothing, and match the level of support to the individual's needs. So again, if you're in an acute inpatient service, the level of need and the types of activities we can do are very different to someone in the community who's experiencing different context. So the guidelines are important. It's also important to remember they can act as a barrier to people. So particularly when we're working with a population who's experiencing mental distress, the idea that we're telling people, there's yet something else they're failing at by not doing enough exercise. And it's really important that we don't just put the onus on the individual around that. We need to create the right environment, the right support, the right structures that we actually help people to engage in targeted, appropriate physical activity. If you're interested in the evidence, the most up-to-date evidence review, earlier this year we published a meta-review. So this was a review of 26 individual systematic reviews looking at the benefits of exercise for mental and substance use disorders. And that was in sports medicine, again, led by PhD student Garcia Ashdown-Franks. Now, one of the important things here is that when we talk about the mental health benefits of physical activity, not all is equal, and it's really important. So there's different types. We've got 4 different types of physical activity. The first one is leisure time or recreational physical activity. The second one is occupational physical activity, so what we do at work. We've got household activity, and also transport related physical activity. Now, unsurprisingly, they're not all equally as good for our mental health as the other. So leisure time and transport seem to be associated with positive mental health benefits. And that's not really a surprise, because what's probably driving that is this idea of agency, this idea of choice, but also the context in which people live, people work. There's an emerging concept and data showing that leisure time physical activity is essentially a class privilege. If we are living in communities where it's not safe, or there's no footpaths, or we don't have shoes, we've got to be really careful about just simply saying, look, we need to do 150 minutes of exercise, because it's actually not possible in a lot of contexts. And if people are in an environment where they don't have the resources, so things like childcare can all be essential barriers that we need to think about. But occupational physical activity, so what we do at work, if we're things like manual labouring and household activities, don't have the same relationship with positive mental health. And in fact, high levels of occupational physical activity go the other way, are associated with mental ill health. So it's not as simple as just telling people, look, try and be more active and do more. We need to think about the domains or the context in which the physical activity is taking place. Again, I'm going to run through this evidence very quickly. It's just to let you know that it is there. An example of the translation, and Jorge spoke in the introduction about the sort of lag between clinical practice and research, and that gap is on average about 17 years. It takes about 17 years to translate a tiny fraction of the research we have into services that actually have a meaningful impact on people's lives. An example of trying to speed that up is here at Black Dog. This is a clinic led by one of my PhD students, Grace McEwen. And this clinic has been embedded within the Black Dog as part of the clinical service. So again, it's really important to stress that it's not this added extra, it's actually embedded as part of the services that are provided to people receiving treatment. Again, the evidence, we did a meta-analysis led by a colleague and friend, Felipe Schuch in Brazil in 2016, where we looked at all the evidence around exercise and depression and essentially showed that we're probably underestimating the actual effect based on the research designs. Resistance training, I mentioned that earlier, but again, another great review looking at the antidepressive effects of resistance training. And probably even more exciting is this idea of prevention. I'm going to talk a bit about this, but we've 2 papers published in 2018, again, one led by Felipe, both in the American Journal of Psychiatry, looking at the idea about whether physical activity is protective against developing depression. And taken together, these 2 studies show that if we got the population moving by as little as 60 minutes extra per week, and again, it doesn't matter the type of activity, the intensity is also not that important, it's just about getting moving for those 60 minutes. We could prevent somewhere between 12 and 17% of incident cases of depression globally. So that's regardless of location, regardless of age. So this idea about physical activity being protective is super important, I think particularly relevant during COVID times, and making sure that we keep people active. Similarly, in severe or serious mental illness, we're talking about schizophrenia, bipolar disorder, there's a few interesting points here. One is also around prevention. We know that a lot of the medication that's provided, and this is antipsychotic medication that is absolutely needed, but we know it has a huge detrimental impact on cardiometabolic health. In as little as 12 weeks, we sort of standard weight gain in young people taking these drugs is 7 to 9 kilograms. It has an enormous effect on cardiometabolic health and subsequently life expectancy as well. And here in Australia, in many ways, we're leading the world in terms of developing programs to actually prevent these things from happening in the first place, prevent this weight gain. And I'm just going to flick through these quickly. Again, it's just some of the guidelines, including World Health Organization guidelines, stressing the importance of intervening early with these interventions. PTSD, similarly, that there's not quite as much evidence, but it is an emerging field looking at the role of exercise. We've got a couple of trials and a few reviews. For people interested in this area, I would strongly encourage you to look at the lifestyle interventions for traumatic stress special interest group that we've just launched together with the co-chair, Dr. James Whitworth from the US, and also ASTSS, are really focusing on addressing the holistic health of people experiencing this. 2 papers I just want to put here about these were written targeting children, so young people, in an interesting journal called Frontiers for Young Minds. But it explains, these 2 articles explain the relationship between nutrition and also exercise and the impact on mental health for a really young audience. Now moving on to the more specific work that we were doing in Bangladesh, and how we sort of try to translate what we know, here in Australia to that context. And one of the things that really got me interested there is some data around children exposed to adverse childhood events, and some strong data showing that participation in team sports is protective against developing future mental illness. And that's really not a surprise when we look at the data around preventing depression in the general population or in the adult population. The fact that a similar relationship would be there among children exposed to adverse childhood events is not really a surprise. And I think this is really important when we think about contexts of displacement, and we think about trauma and torture settings. Thinking about children engaged in sport is one of the key things. And one of the big factors for me in working in Bangladesh was actually working with Sean Nemaran from STARTS, and it's really thanks to him that a lot of this work happened. I remember talking to him one day about this concept, and he was sort of saying that, well, if you give a kid a ball, they're going to kick it, and then they're going to look for a friend to kick it to. And I think that sort of sums it up beautifully, the sort of relationship here and how important participation in physical activity and sport can be for this group. Now, the work that we've been doing in Bangladesh, we've had a few trips over there, but we published some work late last year looking at a rapid community assessment we did among the Rohingya community living in Bangladesh. And what we found there was some really unsurprising but interesting reports around how the community viewed physical activity as a way of dealing with what they described as tension, which is a local idiom of distress. You know, and again, taken together, all the results kind of just show us that it actually doesn't matter about the context in which someone's living, whether it is in a camp in Bangladesh or whether it's here in the eastern suburbs of Sydney. The benefits and the mental health benefits of physical activity seem to be the same. We also heard stories of women that were waking up before the men were awake in the camps and going on walking groups together. And again, that was community organized, community driven. That's not stuff that we were doing. And I think one of the really important things to stress here is that this isn't about us going in and telling a community how to exercise or how to be active. That's actually inherent. That's within the community itself. They've got the skills, they've got the knowledge. They just need the opportunity and they need the resources. And I think part of our role is actually looking at redefining what we consider as routine MHPSS or mental health and psychosocial support to actually include these sorts of interventions. Now, we weren't the only ones at the time that are sort of interested in this, and some colleagues from IOM and UNHCR were doing some similar work, and again, identifying the barriers. And some of the key things were cultural barriers and also some of the gender issues as well, that actually prevent people from having access. And, you know, one of the things that I need to stress here is that the people that stand to benefit the most are the least likely to have access to sport and physical activity. We're talking women, we're talking people with disabilities within these communities, where there is no opportunity and there is no access to sport. And again, something we did together with Sean and Ruth was develop an animation in Rohingya language to try and communicate this message to the community. And very deliberately, this animation, which is available on YouTube, is a story between a young girl and her mum. And that was, again, very deliberate to try and break down some of those gender issues. And the mum is saying, look, you know, sometimes I feel stressed, I feel anxious. And the young person's saying, look, that's okay. There's things in life that we can't always control, but there are things we can control. And making our bodies physically strong is one of the things we can do. Now, it's not all rosy, and it's not all as simple as just saying, right, we play exercise and people feel better. And that's of course not true. We can cause harm. And this was a really important project led by a friend of mine, Justin Richards, in Gulu in northern Uganda, where he evaluated a soccer program, a football program, which essentially made mental health outcomes worse among a sample of young men, many who were child soldiers previously. Reflecting on that, it's really interesting hearing Justin talk about that, because essentially the issue was that there were a few things. One, the coaches they had in the community were from the local community with no training in mental health. And that brings me back to my first point around the idea about what training is needed to bridge those worlds. So the only thing that these coaches had seen before about football coaching was the English Premier League and young people walking up and down a sideline. The coaches walking up and down the sideline screaming at the players. Now, of course, that's not appropriate in this context where there's high levels of distress and trauma. The second thing is not focusing on competition. And it's really important, we've got some good data here, that we need to think about participation, not competition. You know, able-bodied young men having a competition is fine, but when we think about our role in providing a mental health informed physical activity programs, we need to think beyond competition towards inclusion, towards participation. Now, I use these slides a lot because I think when we talk about these lifestyle interventions, it sums it up beautifully. If we think about the picture on the left, equality, think about these boxes as being the interventions we provide. Equality won't work if we're talking about, you know, people living with trauma and mental illness. Giving everyone the same thing will not work. It won't help people be a part of the game, see over the fence. We actually need equity, which is giving people what they need in order to succeed. So for the population that we're talking about, for high risk, vulnerable people, they need extra support to be physically active and to engage in appropriate physical activity. We do have that here in Australia. We're one of the only countries that through primary care, you can get referrals to clinical exercise physiologists who are trained to provide these sorts of interventions. But unfortunately, the reality is that the people who stand to benefit the most do not have access. And that goes for the same in context of a refugee camp or even here in the community here in Sydney. Now, I know I'm a bit over time, but I'll be wrapping up in about 2 or 3 minutes. I just want to talk briefly about the contribution of sport and physical activity beyond just thinking about the one individual. Now, the Bangkok Declaration, written a few years ago, this is based on the UN Sustainable Development Goals, which was essentially a roadmap to eradicate poverty and achieve equality. There's 17 Sustainable Development Goals, and of those, there are 8 that physical activity has been identified as playing a role, a potential role to help contributing. Now, of course, healthy lives and well-being is a given. Also, education. We know that among young people in particular, sport doesn't quite have a stigma around it. People enjoy it, and the enjoyment factor is critical. It's an avenue to engage people. So in schooling, in traditional mental health care. Gender equity is a huge one, and it's fantastic to see the increase in recognition of female sport, including in Bangladesh, which is really important. Inequalities, building safe communities, and creating just and peaceful societies. Now, the benefits go beyond the individual. An example of that is a report released by UNODC this year on preventing violent extremism through sport. And again, one of the potential avenues that we can be thinking about. So this brings this idea about, well, what is community-based mental health psychosocial support? And I'm sure most people on this call will be familiar with the IASC pyramid. Physical activity is normally considered a level 2 or level 3 intervention. So community and family support, potentially focused. But actually, given the evidence we have, even around things like major depression, schizophrenia, acute psychosis, actually thinking about physical activity as a specialized service, and ensuring that we take the appropriate steps to get there is really important. How do we do that? Well, there's essentially 3 things that we've identified that's really important. One is culture. We need to address the culture of mental health services. We need to make sure that the entire multidisciplinary team is aware of the evidence base and how that can work. Training, so we need to train mental health professionals. We also need to train the physical health professionals, so the physiotherapists, the exercise physiologists, and we need some level of infrastructure as well. It's really important that we do provide some sort of context and environment to actually support people to engage. So more specifically, how do we bridge these links? Well, I think firstly looking at capability and capacity. Let's make sure, I think my slides have gone. Mental health first aid training for the sport and physical activity sector is really important. The mental health sector should be aware of the physical activity guidelines, be aware of the evidence. Looking at the relationship with other non-communicable diseases, heart disease, diabetes, the role of prevention and promotion in there. Promoting inclusion, so prioritizing participation, looking at links with existing community programs, so looking at local sporting organizations, local exercise physiologists, what referral options are available, and make sure that it goes both ways. I think that's they're practical steps that we can all take now, regardless of which end of that sort of quadrant we're working in. And just keeping in mind there are people at the center of this too, that we can have a really meaningful impact on people's lives. This is just a clip from a video that's going around on Facebook led by UNICEF, which is this amazing story of a young Rohingya woman whose dad is teaching her Taekwondo in the camp, and just the look in her eyes when she talks about feeling powerful and how people don't harass her or mess with her. It's a beautiful video. If you can get a hold of it, I'll try and send a link. A couple of other resources, if people are interested. UNHCR have, together with the IOC, have developed this Sport for Protection Toolkit, which offers some really practical advice and guidance around how to actually consider sport as part of protection or as part of MHPSS. And that work's being progressed at the moment through the Olympic Refuge Foundation. And there's currently a think tank on sport in humanitarian settings that's ongoing, which hopes to develop some guidelines and some resources as well. I'll leave it there. I just really need to again thank Sean in particular for all his work and collaboration along the past few years to make this work happen. And I'll leave it there and look forward to the discussion. Thanks, Jorge.